The deep veins of the leg act as a low-pressure circulatory highway, quietly pumping blood against gravity back up to the heart. But when a deep vein thrombosis, or DVT, develops, it effectively shuts down this lane of traffic. This handwritten diagram maps out Virchow's triad, the foundational law of thrombus formation. It breaks down the three primary pillars that trigger a clot: stasis of blood, endothelial injury, and hypercoagulability. When blood flow becomes sluggish, usually from immobilization or bed rest, platelets linger and interact with the vessel walls. Combine that with physical damage to the vein lining from trauma, surgery, or catheters, and the body's natural anti-clotting defenses are disrupted. The third pillar, hypercoagulability, occurs when the system is flooded with procoagulants. Conditions like underlying malignancy or even the use of oral contraceptive pills shift the blood's chemistry to favor excessive clotting. Looking at this clinical features section, we can trace the progression of a severe DVT. It starts as a swollen, pale leg, known as phlegmasia alba dolens, caused by arterial spasm. As venous congestion worsens and oxygen is depleted, it darkens into a blue, cyanic leg, termed phlegmasia cerulea dolens. By mastering Virchow's triad, you can predict exactly how these unseen triggers manifest as swelling and color changes seen in a failing limb. To evaluate this inflammation clinically, we look at the diagnosis block here. Physical provocations like Homan's test, dorsiflexing the foot, and the Moses test, squeezing the calf, can elicit pain. However, these physical signs have limited sensitivity and are no longer reliable as standalone diagnostic tools. Therefore, we rely on a strict investigative algorithm. You start with a highly sensitive D-dimer blood test. If elevated, you escalate directly to the gold standards for confirmation: a Doppler ultrasound to visualize the blood vessel, or magnetic resonance venography. Once confirmed, treatment steps up depending on clot severity. You begin with medical anticoagulants like heparin or warfarin to halt progression. For massive clots, you advance to chemical thrombolytics to break down the blockage. And finally, surgical interventions like venous stenting or an IVC filter. To prevent recurrence, patients require dedicated prophylaxis, specifically compression stockings and injections like low molecular weight heparin or Clexane. This aggressive, stepwise management strategy ensures you intercept a growing DVT before it breaks free, travels to the lungs, and triggers a lethal pulmonary embolism. This anatomical map of the lower limb outlines a golden rule of venous circulation. Blood must strictly flow from the superficial venous system, inward through the perforating veins, and into the deep system. This normal mechanism diagram illustrates the physiological pumps that push this blood against gravity. Calf muscle contractions squeeze the blood upward toward the chest, while one-way venous valves lock shut to prevent it from dropping back down. When those valves fail, blood pools. This pathogenesis is divided into primary, idiopathic valve incompetence and secondary causes, like prolonged standing, pregnancy, or an obstructed deep vein, which dilate the superficial vessel outward. This chronic venous reflux damages the surrounding tissue over time. It starts with brown pigmentation from hemosiderin deposits, progresses to fibrotic skin thickening, and ultimately breaks down into painful varicose ulcers. The mechanical failure of a tiny superficial valve eventually compounds into a devastating chronic breakdown of lower limb tissues. Looking closely at this clinical examination block, consider the Trendelenburg test. If you elevate a patient's leg to empty the veins, apply a tourniquet, and ask them to stand, what happens when you remove that tourniquet if the main valve is incompetent? The blood immediately rushes back down the leg, confirming varicosity. You can also evaluate the mechanics of the vein using the Schwartz sign, where tapping the vein produces a palpable percussion wave traveling along the entire vessel. Treatment progresses from conservative compression to sclerotherapy and finally to surgical ligation. But referencing these surgical complications, physicians must carefully avoid the saphenous nerve at the medial malleolus and the sural nerve on the lateral side during extraction. Mastering these specific clinical tests allows you to isolate the exact point of venous incompetence, enabling targeted, nerve-sparing surgical correction. Shifting from the macrovenous system to the microarterial system, we have Reddened phenomenon. This section details how it acts as an exaggerated, spastic vascular response triggered by cold temperatures or emotional stress. This spasm produces a signature triphasic color sequence in the extremities. First, the tissue turns white due to restricted blood flow and ischemia. Next, it turns blue as the remaining oxygen is depleted, causing cyanosis. Finally, as the spasm relaxes, blood rushes back, turning the tissue a hyperemic red. To manage this overactive constriction, the primary medical intervention is nifedipine, a calcium channel blocker that relaxes the vascular smooth muscle. As you review these conditions, look for these specific indicators. In the deep veins, trace the symptoms back to Virchow's triad. For superficial veins, use the Trendelenburg test to find the mechanical break. And in the microarteries, look for that specific white-blue-red sequence. Whether managing deep clots, failing valves, or arterial spasms, the path to a correct diagnosis requires connecting these physical signs to the specific hemodynamic failure happening beneath the surface.